All right, thank you. Hello, everyone, and welcome again to the HIV in Migratory and Seasonal Agricultural Worker Communities webinar. We'll be examining challenges, impacts, and strategies today. This presentation is brought to you by NCFH and the Valley AIDS Council. For those of you who may not be familiar with NCFH, we are a private nonprofit organization located outside of Austin in Buda, Texas. And our mission is to improve the health of farm worker families. And we do this by providing programs, trainings, and technical assistance and resources. We celebrated our 45th anniversary in 2020, and we're very proud to be able to serve the 174 migrant community health centers in our network who provide primary care services to agricultural worker families. One of the ways that we address our mission is through the Ag Worker Access Campaign. This initiative was launched in 2015 as a joint effort by the National Center for Farm Worker Health, NCFH, and the National Association of Community Health Centers, or NAC. We, along with health center staff and other ag worker advocates, knew that more could be done to increase access to quality healthcare for America's agricultural workers and their families, and thus the Ag Worker Access Campaign was born. We've seen steady increases in the number of ag workers served in health centers since the campaign launched in 2015. In 2019, the UDS data showed we surpassed our halfway milestone of reaching 1 million ag workers in the health center setting. In 2020, we saw a decline due to the impacts of COVID-19 on health centers and on our ag workers. And we are excited to share that in 2021, the UDS data showed we once again surpassed our halfway milestone of 1 million ag workers served in health centers. And we are grateful for the determination and hard work of health centers across the country and are hopeful that we'll continue growing from here. We hope that you'll consider joining this initiative, and you can learn more on our campaign webpage, and the link will come through the chat. So without further ado, I'd like to introduce our speakers for today. We have Armando Molina. He's a native Brownsville, Texas, from Brownsville, Texas. He's dedicated to empowering marginalized communities through capacity development education. Currently, Armando serves as a CHW instructor and capacity development trainer at Valley AIDS Council, where he conducts training sessions focused on HIV prevention and care, while continuing his unwavering commitment to uplifting disadvantaged communities. We also have Peter Coronado, who is the Deputy Chief of Organizational Development and the South Central ATC LPS Director. He started working with the Valley AIDS Council Westbrook Clinic in May of 2003 and has worked in various key departments of the agency that has provided structure to his current profession. So I'm going to pass it off to our presenters to get us started. Thank you so much.
All righty, thank you, Katie, so much. I'm gonna go ahead and share my screen. There we go. All righty, thank you, Katie, for that introduction. Hi, everybody. I'm so happy to be here with you all. And I've been with Valley AIDS Council for now 17 years, and I started as an outreach worker. And it's one of the things I love about my job is how to engage with different diverse communities, right? And how to share that with people. And so in today's presentation, we're really going to talk about HIV in migratory and seasonal agricultural workers communities, examining challenges, impacts, and strategies. Really, if I break it down a little bit, we really want to look at what are the social determinants of health for these communities, and what are the health disparities as well, and how do we overcome those challenges in order to help them. It's super important, and so I'm glad you all are here with us today. So let's get started. So I have no disclosure statements. However, I have nothing to disclose. However, Peter does. He did speak last year with Gilead. However, that relationship they're not together anymore. However, we still have to mention that. But in today's presentation, we're not going to name any brand names or any organizations that we can't mention. So that's not going to be part of today's training. And we got to remember that language is always changing. So we want to make sure that we're using language that's unbiased, and maybe there are terms that I might say that has changed. Please let me know. I'm always learning on new languages, things that have changed. So and I am new to this agricultural part of this type of session. So if I say anything, please let me know in the chat box. I'm here to learn as well, and we're all here to learn from each other and together. So thank you. And that way I can update today's presentation and use it for future references and update it and make it better. Today's learning objectives is to define the unique challenges that farm workers face in relation to HIV, access to healthcare, and stigma. So, like I said, we really want to define those challenges. And we want to identify the basic impacts of HIV on farm workers' health, including medical mistrust, learn strategies and interventions that help mitigate HIV transmission and improve healthcare access. So you're going to see at the beginning of today's presentation that biomedical science has, with HIV, in the last 40 plus years has been tremendous. There are medications out there that people could take to prevent them from getting HIV. People would take medications and it works well, so well for this chronic illness that they could be undetectable for HIV. We're going to talk about that as well. However, if we really want to end the domestic HIV/AIDS epidemic, it will require collaborative, innovative, and community-informed approaches, since the factors fueling the epidemic in the United States are largely social and structural. So in today's presentation, any training that we do, there will be some science involved with it, but really there's going to be a social aspect, because learning how to engage with marginalized communities is so important in order for them to stay in care. Well, first of all, get into care, right? And then to stay into care and be adherent to their medication. So those social factors are going to determine whether that person has a healthy outcome or not. So here at Valley AIDS Council, where I work, these are the services that we do provide. We provide prevention services like HIV testing, and we test for HIV for free, STIs, hepatitis C at no cost for the person to come in and get tested. And the age that people can come into and get tested with the CDC guidelines is anybody from 13 years old up to 65. However, what we've learned lately is that people are still having sex after 65. So we'll say 13 and up. And we really want to make, make it, normalize it to where people have routine testing for these types of HIV and STIs and hepatitis C, including other lab tests that should be done annually. And learning family health history is super important. And so once somebody learns that, they can know what to go in and get their labs done for, including these. And treatment services. We have treatment services for HIV, STIs, hepatitis C, gender affirming care as well, and also HRT, hormone replacement therapy. So we provide these types of treatment services here at Valley AIDS Council as well. And we have social services as that case management can help, linkage to care, services that address social determinants of health, such as transportation. We have those types of services for our patients and clients as well. And we provide trainings for healthcare community, just like we're doing today at no cost. We think that's super important. When I'm looking at announcements for community health workers that they can get, 6 hours or plus of certified CUs from DSHS, and it costs about $1,000 to $1,200. I personally think that's ridiculous. So all our trainings and sessions are always at no cost for the attendees. So in this first module here, we really want to talk about, the overview of HIV and HIV stage 3, also known as AIDS. And we really don't use that acronym AIDS anymore, because really people don't get to that stage if they take their medication. And even us at Valley AIDS Council are debating whether we should change our name, our organizational name, or not. And so that is still in the works. as well. So we really don't use the acronym AIDS as often as we used to. We really use HIV stage 3. We're going to talk about that as well. So really simple. HIV, what does it stand for? Human immunodeficiency virus. I really just want to start here because maybe not everyone here, the 75 attendees that are here today, know what really HIV stands for. Might not happen. And when I used to do outreach and engage with the community and ask them, what do you know about HIV? I would get like so many like animal questions, like, oh, where did it come from? I once took my cat to the vet and it had feline AIDS. Oh, if a mosquito gets on somebody that has HIV and comes to me, can I get HIV? So really with the H, it stands for human. Only humans can get HIV and only humans can give it to other humans for HIV. So HIV cannot live in a mosquito's DNA or anything like that. So it's important to know only humans can get it and pass it on to other humans. And immunodeficiency, really, that's refers to a lack of deficiency or breakdown of the immune system. That's exactly what it's doing to the body. It can take years and years before somebody notices anything like any symptoms or signs that their immune system is breaking down. And it's a virus. So a virus attacks and destroys the immune system, which usually able to defend against infections. And usually if it's a virus, that means there's no medication that can cure it. The only virus I know that's curable is a hepatitis C virus. So AIDS and stage 3 HIV. So AIDS stands for acquired immunodeficiency syndrome. Okay, so they break it down that way. Acquired means to happen over a period of time, and immunodeficiency is breaking down the immune system, and syndrome is, a lot of bad things is happening to the body at once. One of the biggest difference between HIV and HIV stage 3 is that usually people that have HIV is usually asymptomatic. They're not showing any signs or any symptoms or anything like that. So what happens is people don't want to, people are not like, hey, I'm feeling sick. I need to go in and get tested or go to the hospital and see what's wrong with me. So they feel as healthy as they always did all their life. And so a lot of times people think, well, if I don't feel sick, I don't need to go in and see a doctor. However, there needs to be preventative care. And that's something that we need to normalize in our culture in this country is that preventative care is super important. So knowing family health history and getting tested for various things for preventative care is super important. Not just wait until we get sick or wait another 2 weeks after we are sick, see if we get over it, and then finally somebody pulls us out of bed and we go in and get the care that we need. So HIV stage 3 is a stage of the effect that the virus has in the body. And so updating our language to destigmatize HIV is super important, or to destigmatize AIDS as well is super important. And I know we're Valley AIDS Council and everything like that. However, we do not have any signage on any of our buildings. It's super blank. We have people coming in and thinking that it's a primary care physician clinic or anything like that. And so we really just call it Westbrook Clinic outside. So whoever comes doesn't feel like they're being stigmatized against, or it perceives any kind of discrimination not coming in and get the care that they need. So just to have a visual effect, these are the stages of HIV. So before HIV infection, you can see there that those are the CD4 cells. That first vial of blood on the very left, those blue. So those are the CD4 cells there. That's your immune system. That's what keeps us healthy. That's what fights off viruses and infections and things like that. And then let's say somebody shared a needle and they go in and get tested and they have an acute HIV infection. That's HIV stage 1. Okay. And that could be a few weeks. It could maybe take 2 to 4 weeks or even 3 months for this acute HIV infection to happen. And you can see that there's a lot of HIV cells in there and mixed with the CD4s. And so really the HIV is attacking the body. All right. However, when it becomes HIV stage 2, which is a chronic HIV infection, and we can see here that there's less HIV in there, and that's really the body's response, the body's response in trying to fight off the virus. And you can see there's a lot less HIV virus there in the chronic HIV, that first vial. However, as years go by, since it is attacking the immune system, that body is going to lose that fight eventually later on. So you can see less CD4 and more HIV cells in those vials of blood. And at the end there, where the acronym AIDS is at the very last viral, you can see that it's only one CD4 cell in there and a lot of HIV virus. And so the AIDS, that's what we call it HIV stage 3. They're at that point in time in the virus. And usually that's when people see signs and symptoms, are very sick, they end up in the hospital. They want to know what's going on with them. They have flu-like symptoms, maybe suffering from wasting syndrome and wondering what's going on. And so, and that could take up to 10 years. And so maybe somebody had HIV for 10 years, didn't know it, and they're in the hospital getting tested. Not only do they test positive for HIV, however, they can get an HIV stage 3 or AIDS diagnosis at that time. And so that's very prevalent in the Latino community, in the Latinx population. They did a study and found out that we're the worst to go get preventative care and really don't go until we get sick. And not only that, we don't have a PCP because we don't get preventative care, and we end up a lot of times in the emergency room trying to get care there. And if somebody does test positive for HIV, and even in the HIV stage 3, they will refer them to us here at Valley AIDS Council. So treatment as prevention. Like I said, medications for HIV has come a long way in the last 40 plus years. And so treatment as prevention, this didn't exist 17 years ago when I started. So advancement in medical therapies like antiretroviral medication, of a person takes their HIV medication and they are a person living with HIV, then they can get to an undetectable status, will be untransmittable as well. However, there are medications out there like pre-exposure prophylaxis, also known as PrEP, right? And also post-exposure prophylaxis, also known as PEP. So with PrEP, a person can take one pill a day or even an injection every 2 months, and it'll prevent them from getting HIV, okay? And so they can be taking that medication, and that could even be up to 99% effective of preventing HIV to happen. However, with PEP, with post-exposure prophylaxis, a person can take that within 72 hours after exposure from HIV, and they can start on that regimen. And they would have to take that medication for up to 28 days in order for it to be effective. And we're talking about 87% effective if they do take it every day. And so it'll prevent them from getting HIV within 72 hours. Remember, they got to start this 72 hours from exposure. So this is after the fact. And then we have harm reduction services as well at Valley AIDS Council. And so there obviously needle exchange services does not exist in the state of Texas, only in San Antonio. However, there aren't any needle exchange services where we are at. And so we do offer like bleach kits where they can clean syringes and needles with water, and it does kill the HIV virus in there. So just in case they do share needles or anything like that. So we do provide those types of kits of harm reduction out there, and we do teach harm reduction techniques. And I always remind them, it's not going to be the numbers of prevention is not going to be the same. It's going to be a lot lower since it is a harm reduction method and not a prevention method. Okay. And so importance of U equals U, undetectable equals untransmittable. It's so important, when I was working with people living with HIV and doing interventions with them, they had a common denominator of living alone for the rest of life, not starting a family. That made them probably make choices of, not taking their medication. They were suffering from depression due to the stigma that comes with living with HIV. So reducing the stigma is super important. And not only that, since they're undetectable and untransmittable for HIV, it does reduce the transmission of HIV as well. And it's going to help end the HIV epidemic here in the United States. I just read an article a few weeks ago that Amsterdam really amped up their PrEP, marketing PrEP and getting PrEP out there in the community and all that. And they reduced HIV new transmission by 95%, which is remarkable. So treatment as prevention, also medications of, antiretroviral therapy for people living with HIV. These medications were tremendous and it works. However, people are, we got to ask ourselves, why aren't people that are living with HIV getting on these meds as often as they should? And what about the people that are vulnerable getting HIV? Why, what are the reasons that they're not getting on this medication as well? So those are the determinants that we do have to identify. And here are the 4 pillars of the continuum of care diagnose all people with HIV as early as possible, treat people with HIV rapidly and effectively to reach sustained viral suppression, and prevent new HIV transmission by using proven interventions, including PrEP and syringe service programs, and respond quickly to potential HIV outbreaks to get needed prevention and treatment services to people who need them. And you know what? This is why it's so important that we're talking about this population, because if we want to end the HIV epidemic in the United States, we have to serve all populations that are in the United States. And so we really want to talk about today the unique challenges of the farm worker communities and what they face. And when I did HIV 101 trainings and I'm talking to communities, I would always mention, people suffer from these social determinants of health in a wide basis. However, it magnifies more for people who are undocumented and for people that are part of the LGBT population as well, because the a fear of perceived discrimination and the stigmas that come along with it. And they might not feel comfortable getting into care and staying into care. So one of the main challenges that we often see is language, right? It's hard enough already. English is I'm real prevalent with English, and even myself, if I'm talking to a doctor and they're going to use medical jargon, like use like L5 vertebrae and this and that, suffer contusions and things, just a general population out there is not going to understand that type of language. And so let alone if a person is English is not their first language at all, it's gonna, like I said, it's gonna magnify that power dynamic, that gap. Okay, and that's what we want to identify today, is really try to diminish that gap of power dynamic, not only in society, but between provider and patient. So interpretations services, or having somebody in the room that speaks the language, not relying on their 5-year-old kid learning this language from the doctor and relaying it to the parents or anything like that. That's not going to work. We have to use, really really good language services they're provided to try to diminish that dynamic of power dynamics between provider and client, and letting them really understand what's going on with them. What is the medications that they're taking? I know I have family members and friends that speak English and they don't even know what medications they're taking. They just say, you know what, I'm taking a blue pill in the morning and a yellow pill at night. That's all I know. And so really breaking down that language and acronyms is going to be super important. And not only that, the culture related stigmas and even religious stigmas that come into play in the Latinx cultures is going to be magnified as well. So not talking about sex, right? And if they do talk about sex, are they going to talk about sex that's non-heteronormative, same-sex couples? It's going to be maybe due to cultural norms and religious norms, that person's not going to want to come out of the closet or talk to their parents about what's going on with them, or even want to talk to their providers of what type of sex are they having, what makes them vulnerable of getting certain health things, or what can they do to better their health as well. So they need that culture related stigma. Just stigma in itself is going to be a challenge. Proximity to health centers. If they're out in the country, in the middle of nowhere, anything like that, can they get access to transportation, or do they have access to certain health centers that they need to go to? And if they migrate from one place to another, maybe they have met somebody in one place that has helped them out in health-wise, and however, maybe they moved months later and they have to find a new place. So just finding those proximity health centers for them to get access to care could be extremely challenging. And continuity of care affected by constant mobility. This is what I was saying, right? So maybe they got to care, but they need to move somewhere else for work or get back with their families or anything like that. They're constantly mobile. Then they have to find somebody, hopefully wherever they're at that time, refers them to other clinics or wherever they're going to. And another challenge is knowing their rights in the United States. What rights do they know? Or what services do they know that's for them? How do they know they're not being discriminated against or being taken advantage of? Maybe even unreported sexual assault, right? As well. Maybe they don't want to report it because they could lose their job, or their fear of being sent back to wherever they were, things like that. And so there's that fear component as well, not wanting to speak up. So, like I said, let alone already the general population in the United States have those fears of being stigmatized and being discriminated against, whether they're a person of color or a gender and sexual minority. But these challenges are way more magnified for people that are part of the undocumented population and for LGBTQ plus populations as well. And we're going to talk about intersectionality. And I've talked about undocumented populations and LGBTQ, but what would happen if a person intersects with both identities, right? And that is something that we really do need to address as well. And other challenges is migrants or farm workers living in high income countries are disproportionately affected by HIV and frequently have poor HIV clinical outcomes. Uh, Farm workers acquire HIV. So when we did this research, we found out that they acquire HIV after migration, and it's usually a late diagnosis that often occurs for them. And you know what? There are few studies that have examined interventions targeted to improve HIV outcome among farm workers as well. So high proportions of farm workers acquire HIV after migration, and this group frequently presents to care late. Once established in the care, farm workers are often more likely to experience worse HIV treatment outcomes compared to native populations. And so there are multiple individual and structural factors that influence HIV diagnosis and treatment outcomes among farm workers, including disruption of social networks because maybe they're migrating, increased sexual risk behaviors, communication barriers, limited access to care, and stigma. Few studies have examined, like it says there, that target improved HIV outcomes in these among farm workers in these communities. So I have a question for everybody, and you can put this on the chat box. I don't want to take too much time away, and we're about halfway, so this is really good. I just want you to think about and put it on the chat box. Maybe share some identities of people who might hold power in this country. So who do you think holds power in this country? And you go ahead and put that in the chat box, please. Okay, I see white cisgender heterosexual men, high SES people, the voters. If you can elaborate on SES, let me know what that acronym means. Socioeconomic status. Yes. Thank you. Yes. Corporate community, the rich. Yeah, this is so important for us to identify as well when we're talking about social determinants of health. And, some people have shared some identities of, socioeconomic status. And, there's a phrase like, oh, the rich kept getting richer and the poor keeps getting poorer, right? And so these are, when we talk about social determinants of health and who holds power in this country, we really have to identify that as well. And who makes these decision-making and policy makers as well. And so what intersectionality and how does it affect our migrant communities? So when we're talking about intersectionalities, maybe certain identities out there that are intersectional, like I saw white cisgender men. So white cisgender men, I mean, those are three intersectionalities of identities plus socioeconomic status. Those going to be four intersectionalities of identities there that we identified for who holds power in this country. Government as well. Thank you for that. So thank you all for participating in this question, and thank you for being here. So we're going to move on to impacts of HIV on migrant communities. I believe Peter is here now. I don't know if he can jump
Hi,
on.
everyone. Hola. Y'all can hear me, right? Okay, perfect. Thank you for that, Armando, and kind of leading into the impact of HIV in migrant communities. So it's good that we kind of go from trying to identify who holds power in this country, right? And how does that even affect our communities, right? Our agricultural communities, because we want to kind of keep in mind that sometimes our health disparities are driven for the most part based on some of these social determinants of health, which can be no, for example, somebody said, or Rosa mentioned, informed communities, right? So when we talk about health literacy, if people are not even aware of where to go get an HIV test, or that it's free, they may not, or how to protect themselves from acquiring HIV, then that is an uninformed community, which at that point puts them in a very vulnerable position where they can be able to acquire HIV, right? If you're rich and wealthy, most likely you have health insurance. So all of these things kind of like, play into how HIV impacts our migrant communities. Think about the migrant communities you work with, and think of them, how many of them are what you all said here, how many of these migrant communities are white, cisgender, heterosexual men, high, income, socioeconomic status? How many of those are rich and wealthy, and how many of those are informed communities, right? So just kind of think about it. So I don't know who has control of the slides, but if we can go to the next one. Okay, perfect. Thank you. So this just kind of gives you an idea of what, when it comes to new diagnoses of HIV by race and ethnicity, we do see that for the most part, the community that tends to take most of the brunt of new HIV diagnoses are Black African American individuals, right? So that's at 40%. Then we have Hispanic, Latino communities that are highly impacted by HIV, and we're gonna go a little bit over even that percentage itself. That 29% might not sound like a lot maybe to someone else, but for us it does, right? Because what is the percentage of Latinos that represent this country, right? That's 19%. So we see that health disparity, that we are 19%. Well, we meaning me and anybody else that identifies as Hispanic or Latino. We represent 19% of the community here in this country, but we also account for 29% of new diagnosis of HIV. Now, when it comes to Black African American communities, right, we know that people that are working in farms, farm workers, not necessarily means that they're all Latino or Hispanic, but we do see that the majority can be. We do have other groups that also work in some of these areas as well. So we can go to the next slide, please. The impact when it comes to new diagnoses in 2021 by subpopulation, right? So this is when we talk about more of the mode of transmission. I think earlier somebody asked, what is the kind of like the mode of transmission, the route of transmission, right, of how HIV is passed on from one person to another. For the most part, is through sexual contact, what we see. If we focus, let's say we just focus on our Hispanic Latino communities, we do see that the majority of the way that people acquired HIV was male-to-male sexual contact. And if we go down to our Hispanic Latina women, it was through also heterosexual contact, right? So Latina women, for the most part, tend to be at higher rates of acquiring HIV than their white counterparts, Caucasian Latinas. So we think about who are these women having sex with, right? There's some bigger chance that they might be having sex with other Latinos or with male Latinos. So we kind of see those disparities and those high rates, right? And as you can see on this slide, we don't say gay, bisexual. We just mean specifically just men who have sex with men, because it could be survival sex, or it could be, people might not share that identity with gay or bisexual men. If we can go back, I'm sorry, you can go to the next slide, please. So when we talk about historical trauma and medical mistrust, right? So I can speak for myself and say that I grew up accessing more traditional folk healing medicine, going to curanderos, soanderos, to be able to, and that was our healthcare growing up in a rural part of Mexico, and even in living in the US. It was easier for my mother to take us to a sobandera or soandero, natural folk healer, than to take us to the doctor. It was expensive to take us to the doctor. If we didn't have health insurance, how can we afford that, right? So, so there's this medical mistrust, and a lot of it comes historically. And by this point, some of you already read this slide, right? So it just kind of goes to show that, not only with our Latino communities, but also even within our Black communities, right? When we look at like the Tuskegee program, right? Kind of what happened where they intentionally were leaving Black men with syphilis to see the effects, and they weren't giving them the treatment, right? And then when we look at, for example, with Latinas here, they were coerced to be able to get to agree to be sterilized because the consent forms were written in English. It goes back to what Rosa mentioned, right, when she said informed communities, right? If you're an informed community, you're going to have a power over your healthcare. If you're not informed, then you're not. There's a bigger chance that you're not going to be able to access the adequate healthcare. There's another instance, right, in Georgia when it comes to our asylum seekers. It was also known that there were women specifically that were being sterilized, not knowing, or there were hysterectomies were being performed on them when it wasn't necessary. You come with your own conclusion of why that is. So there's that medical mistrust that comes from our community as well. You can go to the next slide, please. And I'll answer your question right now, Crystal. So 61% of migrants seroconverted after arrival in the US. This is data of people that were newly diagnosed with HIV in New York City. So what does this mean? That 61% of those migrants acquired HIV, and it was after the fact. So like Armando said earlier, right? People are not coming into this country with HIV. Yes, there is some, but what happens for the most part is that they acquire HIV here in the United States, right? A lot of times what happens is that, there's the disparities there. It just goes back to, do they have the information? Do they know that there's prevention methods, right? When I think earlier somebody also asked, what is the prevalence, right, of HIV, within these communities? And it ranges between 3.5 to 13%, right? It's still a high number when you think about the amount of people that are actual, that are farm workers and are part of the farm worker communities. So it's an alarming rate of the people that are acquiring HIV within these communities. Women, for the most part, when it comes to overall in the United States, you're looking at almost 20% of them that are of new HIV infections are amongst women, right? And then when you break it down, yes, it's more primarily within Black women, but when it comes to Latinas and Latinas that are in farm worker communities, within farm worker communities, for the most part, they are more vulnerable to acquiring HIV, because a lot of times what happens is that there might be sexual assault within their own marriage. There might be sexual assault within where they're doing the farm work. Some of them may or may not know, well, like Armando said, right, they might not know their rights. Then what comes with sexual assault, right? The stigma behind it, right? To where, are they going to listen to them? Are they going to believe them? Are they going to get in trouble with the law? So many factors play when Latinas specifically within this community, where they don't say much, right? There was a recent I don't want to call it, well, it's a news programming, right? So there's this show called last week with John Oliver, and the focus was on migrant communities, on farm workers, right? People who put food on our tables. And Dolores Huerta comes out and kind of like talking about, there's a snippet of it, right, saying about how the harassment that women go through in working in farms, and a lot of times it just goes, without anybody saying anything. Next slide, please. So some of the strategies and interventions that we want to apply within these communities, right? And we can go to the next slide. We need to start destigmatizing HIV within our migrant communities. There's a story, right? I like to kind of tell some of these stories. Armando and I were doing some kind of training over there in Monterey, California, not Monterrey, in Mexico, but in Monterey, California. So we're doing some kind of training, and over there, where all the rich people live. And then we were looking for a place to go hang out and have a drink, right? So we decided to go to this town right off, like way out there, and it was like in the middle of these strawberry fields, right? So it was a cantina. There was like Tejano music playing. And if anybody has watched the novela Sinvergüenza, there's a scene there where these guys are going into a Tejano bar, and it just happens to be that it's a LGBTQ Tejano bar. So primarily a lot of gay men, lesbians in that bar. So nowhere there did I see any information about getting condoms, testing for HIV, even just about healthcare stuff, right? And the majority of the people within that community, they were monolingual, Spanish speaking only. And I cannot assume, but this bar in the middle of almost nowhere, in the middle of all these fields, which was really fun, by the way. It just kind of goes to show that, maybe there's not a lot of information out there, and people are still going to go have fun. Regardless, they're going to find a time to go have a good time, right? Either by themselves or with somebody else. So there's a lot of stigma still that, limits access to care. And stigma itself is a big driver to poor health outcomes, especially to our migrant communities. If a lot of these migrant communities come from a very religious background. So when we talk about entities that hold power, religious institutions hold a lot of power, right? So maybe when we talk about using protection when you're having sex, or even just talking about premarital sex, or sex between two people of the same gender, they don't want to talk about it. If they don't talk about it, it doesn't happen. Next slide, please. Culture, humility, and awareness, right? So if we're providing a service out to the community, we need to be aware of kind of what can happen, right? It's very easy for me to say, oh, well, let's talk to everybody about HIV and condoms and lube and pre-exposure prophylaxis prep, right, to prevent HIV. But it works differently for every community. We have to be careful and be respectful at the same time, right? That if there's a very religious stronghold within that community, we need to kind of navigate that, right? Addressing legal and policy barriers, right? So make sure that people know what their rights are. It's super important in order for us to be having healthy communities. That if there's women or men or any person, right, transgender individuals that are victims of sexual assault, that they know what their rights are. Community engagement and peer support. A lot of these programs will not work if we are not a member of that community. They do work if we have maybe some experience, but you're going to be very, very, very successful if you at least partner up with somebody that is part of the community, right? So if you have people that you're working within these groups, right, there's a program, and not to say that it's exactly the same, right, but there's a program in New Mexico where and it's in their justice system, right, in the jails. So they have this program where they train people that are in jail. They train them on prevention for hepatitis C, because there's a lot of tattoos and drugs, right, that are drivers of Hep C. So they're teaching them so they can be able to teach their peers in the system on how to protect themselves, on how to clean their needles, on if they're going to be sharing needles for tattoos or sharing ink for tattoos or whatever, what is the best proper way so they don't transmit HIV. So even doing this, right, and be able to train people that are within the community so they can be able to train their peers, right? And I'm a community health worker, Armando's a community health worker. We know the power that community health workers hold. They have so much knowledge. They know a little bit about everything, right? So, and they know how to connect with the community. So if you don't have community health workers working for your organization, you're missing out. They're a crucial a part of the workforce that I think every healthcare institution, program, organization should have, because they're gonna get a return on investment. Next slide, please. Language access, right? So making sure that not everybody who comes from Latin America speaks Spanish. So, and obviously probably within this group we know, right? So making sure that if we're working with communities also that come from indigenous communities, and to be able to make sure that there's somebody that can speak their dialect or have a program. Now we have everything on an iPhone, right? So I was at the airport the other day, and I remember seeing this woman trying to communicate with the counter person at the airline, and they were using Google Translate, so that she would type in something, and then she would put the phone, press play, and then it would say it in English, and then the other way around, and they would say it in Spanish, right? So try to come up with different ways to be able to communicate with the community. If you don't have the funds, like I said, Google Translate. Collaboration with other non-governmental organizations or community organizations, right? If you yourself cannot afford to have those community health workers, maybe there's a group that has, right? And they can be able to provide some of that information. Tag along, right? Why not? If you're maybe you can work with a community health center that maybe takes a mobile unit right out there, and that you can be able to work with them. They can give you a ride to be able to also get there and be able to provide that information or resources to the community. We understand that maybe you're in a field and you're not going to be able to get everybody to come in and get tested or whatever the case may be, or even listen to you for more than 5 minutes. But maybe just kind of trying to come up with a innovative way to where you at least provide them with food, water, something, snacks, whatever it is, and at least give them some information that they can take with them. So whenever they do have the time to look at it or read it or whatever the case may be, that they have that. So data collection and research, and we can go to the next slide, and I'll talk about data collection and research, is that there's not a lot of studies out there, to be honest with you, that there's not a lot of studies to identify if there's any strategies or interventions that work best for this type of community. The investment has not been there, and it's very sad because these are individuals who are putting food on our table, right? These are people that, for the most part, always have to be fighting just to make at least a minimum wage, right? If anything, so research data. If you're somebody who does research, make sure to kind of collect that data of even asking a simple question: have you ever tested for HIV, or do you know what HIV is, right? And at least you'll get a lot of information from that, right? Because you might find out that they don't even know. They might even come from countries that they haven't really been affected by HIV. So they're thinking 80s, 90s back in the day, and it's gone. And they're not really thinking about what's going on in the present moment. So meet them where they're at. That's kind of what I was talking about, right? Going out in the fields. Distribution of condoms, educational material, same thing, right? If you don't have enough time to be there to provide all this information, just give it to them quick enough to where they can go home and they can be able to read that information. The next slides, please. And then any tips to support and destigmatize same gender sex amongst these Latino communities, given there's a lot of gender role, religious beliefs. Yeah, so I think one way to destigmatize it is to at least talk about it. So one of the things that that Armando and I do when we do trainings for community health workers, a lot of times they come across people that they're just they're very ingrained within their religion and they believe a certain way, right? But a lot of times when we're having conversations, we have a video where it shows like this same gender loving couple, right? And at least it opens up the conversation, right? And as long as people can start talking about it and you can navigate the conversation till we say, okay, we're not here to like say if it's wrong or right or whatever the case is, but as long as you're talking about it, right? We always need to kind of remind people that we don't know who's listening around us, and it might be our children, it might be somebody we love, our friends, whatever the case may be, that if we say something that destigmatizes them of who they are, it can have a long-lasting impact. And that in itself, stigma, homophobia, transphobia, biphobia, all of that, right, is a driver of health disparities. So we talked about mobile clinics, we talked about or even telemedicine services, right? I know some places, maybe Marfa in West Texas is not the best example, but Marfa obviously also maybe a little bit more, I don't want to say completely privileged, but they have a little bit more privilege, right? So a lot of artists out there. Marfa, the small town in West Texas, they're working with an organization in El Paso. El Paso provides telemedicine services, and they use their local library as a place where they can go and access the telemedicine service, because that's where they have like adequate internet service, right? I haven't been to Marfa. I just, this is just an intervention that they mentioned to me, which I thought was pretty innovative, right? And Marfa's small town, right? So just kind of thinking about, are there spaces within your community? It can be a space that you never thought about, right? That they can be able to at least have a room for you with a laptop, internet, so you can be able to provide the telemedicine service, right? Next slide, please. And, when we talk about, why don't you kind of just use this slide real quick? I've been talking about, right, social determinants of health or drivers to health disparities. What are the behaviors, right? So this is just one example, right? When it comes to, health disparities, lack of education, poverty, lack of access to care. Those social determinants lead to behaviors of unhealthy eating, smoking, exposure to STIs, which then lead to health disparities, right? High blood pressure, cancer, obesity, diabetes, and HIV, right? So, this is just one prime example. You can do your own like tree with finding out the roots, and the roots are your social determinants of health. Your branches are your and the trunk, right, and the branches are your behaviors, and the health disparities are the leaves, right? So that's a good way to identify what is it that your community needs. Next slide. And just some food for thought, as I'm eating my finger. Just food for thought. Moving allyship to activism is about looking for ways that you as a person in a privileged position can truly uplift the voices of those who are often out on the front lines of change. We all have some type of privilege, right? If it's because we know 2 languages, if it's because we have an 8 to 5 job, it's because we have health insurance, if it's because of the color of our skin, even though I'm Latino, am I lighter than my brother, right, who's a little darker? So those are all privileges. We need to kind of think about what our privileges are, right, and what kind of position of power we hold, and how we can utilize that for the good, right? And last slide, I think it's our thank you. These are our references. And the following slide is also going to show you some resources. If you're a clinical provider and you're maybe going to start doing PrEP, right? And we'll talk about PrEP and maybe in the next training and other prevention methods. If you want to talk about if you're going to be doing HIV care prevention services and you don't know where to start, you can call the National Clinician Consultant Center, and they have like a 24-hour, I believe, clinical staff like doctors, MDs, so forth, DOs, that can be able to provide that clinical consultation, peer to peer. There's also all these other trainings that you can be able to access through the National HIV Curriculum, and if you go through the National Coordination Resource Center as well. These are our social media links, well, not links, QR codes. So feel free to follow us on social media for any additional trainings we're doing out there. Thank you. And that's Armando, myself, and our information. Hopefully I answered all the questions.
Thank you very much, Armando and Peter. This has been fantastic presentation.